Hi and welcome to OneMedicine. In this part of rapid revision of rheumatology, we'll be looking at connective tissue disorders. These are a group of heterogeneous disorders that share a certain common features. These common features include inflammation of skin, inflammation of joints, altered pattern of immunoregulation. This includes production of auto-antibodies and abnormalities of cell-mediated immunity. Although there are distinct clinical entities, there are a lot of overlaps that are seen among these patients. So various conditions have almost common symptoms. Let's look at first of these disorders, that is systemic sclerosis. This also includes scleroderma. Systemic sclerosis is a multi-system disorder characterized by thickening of skin, which is called scleroderma, and distinctive involvement of multiple internal organs. Important organs that are involved include the gastrointestinal system, heart, kidneys, and lungs. The pathogenesis is unclear, but certainly involves immunological mechanisms leading to vascular damage and a characteristic feature of activation of fibroblasts. Clinical features can be broadly classified into cutaneous, bone-related, pulmonary, renal, and cardiovascular. Cutaneous features include edema, followed by scleroderma, that is thickening of the skin. There is fibrosis of the skin. There is Raynaud's phenomena, which includes peripheral vasoconstriction leading to bluish discoloration and sometimes even ischemia and necrosis of tips of fingers. There can be telangiectasias. There can be calcinosis of the skin, classically the tips of fingers. This is known as calcinosis cutis. In bone, patients can have arthralgias and there can be arthritis. Pulmonary manifestations can be interstitial lung disease, pulmonary arterial hypertension. Patients can also have alveolitis. Renal involvement may lead to hypertension, and patients can have chronic kidney disease and renal failure as well. Cardiovascular include conduction abnormalities. Patients can also have peri or myocarditis and cardiomyopathy. In the classification of systemic sclerosis, there are two distinct types which can be understood. The first one is diffuse systemic sclerosis, and second one is limited systemic sclerosis. Diffuse is characterized by rapid development of symmetric skin thickening, that is symmetric skin sclerosis, especially of the proximal and distal extremities. There can be sclerosis of the facial skin also and trunk. The characteristic or important feature of diffuse systemic sclerosis is early internal organ involvement. that is especially in the early stages of the disease. Limited systemic sclerosis, on the other hand, presents with a long-standing Raynaud's phenomena in the patient, usually lasting for several years before the development of other symptoms. Skin involvement is limited to fingers, also known as sclerodactyly, that is thickening of the fingers or especially the tips of fingers. And if at all any other parts are involved, that will be the extremities, that is the hands beyond or distal to elbow joint. There can be facial skin involvement also. Facial skin sclerosis can be seen. This generally has a better prognosis. However, an important point to note is limited systemic sclerosis can be associated with higher incidence of pulmonary arterial hypertension. In such patients, the management becomes quite difficult. There is an important subset of limited systemic sclerosis patients who belong to a particular syndrome called CREST syndrome. CREST is an acronym for calcinosis cutis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasias. So these patients, classically, these are the questions that are asked in competitive exams, where the patients will have calcification of the tips of fingers, and along with that, patients can come with recurrent Raynaud's phenomena symptoms. Patient can also complain of dysphagia and also pain or lumpy sensation when swallowing food, that is the esophageal dysmotility. There can be sclerodactyly. On examination, there can be thickening of the palms, skin of the palms, and there can also be telangiectasias. So this particular syndrome is called as CREST syndrome. Let's now look at the evaluation of systemic sclerosis. The first and foremost important part of understanding a particular disease, especially related to connective tissue disorders, where the investigations play a very minimal role, is trying to understand how the patient has had the disease, including the history as well as physical examination. So history and physical examination play a very important role, especially when asking for Raynaud's phenomena, which can be seen in early stages. A history of hypertension, for example, in such patients can be an early sign of renal disease. The laboratory investigations include investigating for erythrocyte sedimentation rate, C-reactive protein levels, which both of which are elevated, as these are acute phase reactants. They are also markers for disease activity in such patients. An important laboratory investigation is anti-nuclear antibody test. Particularly in patients with limited systemic sclerosis, patients can have anti-centromere pattern of anti-nuclear antibody. Specific antibodies involved in systemic sclerosis include anti-SCL70 antibody, which is a anti-topoisomerase 1 antibody. Other tests include radiography, that is chest X-ray can be done to look for features of pulmonary hypertension. Patient can also be subjected to barium swallow to investigate for esophageal dysmotility. Hand X-rays can be done to look for calcinosis and also arthritis changes in the patients, which is seen as distal tuft resorption. Some other studies include pulmonary function test, ECG for conduction abnormalities. There can be skin biopsy, which can also be performed in such patients. With the diagnosis established, let's now look at the treatment in systemic sclerosis. As a general rule, Raynaud's phenomena is triggered by cold weathers or also smoking. So patients with recurrent Raynaud's phenomena can be educated to wear warm clothes and also stop smoking. For patients with esophageal dysmotility, Patients can be educated to have soft and easily swallowable foods. They can also be trained regarding anti-reflux measures. Specific therapies for Raynaud's phenomena include calcium channel blockers such as nifedipine. Other medications for Raynaud's phenomena include sildenafil, which is phosphodiesterase inhibitor. Patients can also be given losartan, nitroglycerin paste, fluoxetine, bosentan, which is an endothelial antagonist. Patients with recurrent Raynaud's phenomena can also be subjected to digital sympathectomy. Other specific therapies include ACE inhibitors. Here it is particularly used in patients with renal disease. This is also known to limit the proteinuria and progression of renal involvement. This can also help in controlling hypertension. For GERD symptoms, H2 receptor blockers such as ranitidine or proton pump inhibitors or antacids or metoclopramide can be used. The next specific therapy is D-penicillamine, which is known to have controversial benefit. It is shown to improve skin thickening. However, if it is used in doses of more than 125 milligrams every alternate day, it is not beneficial. Glucocorticoids are particularly used in patients with inflammatory myositis or carditis. But apart from this, they do not have any role in systemic sclerosis. In fact, high doses may be associated with even renal crisis. So in general, glucocorticoids are completely avoided unless the patient has an inflammatory myositis picture or a carditis. Cyclophosphamide is used in particularly patients with pulmonary involvement, especially patients with pulmonary arterial hypertension, or if there is evidence of alveolitis. This is shown to improve mortality outcomes in such patients. Mycophenolate mofetil is also found to be equally effective in comparison with cyclophosphamide, especially in cases with interstitial lung disease, particularly in patients with pulmonary hypertension. To improve the cardiovascular outcomes, the following medicines have been tried: prostacyclin, that is epoprostenol or treprostinil, endothelin 1 receptor antagonist, that is bosentan, phosphodiesterase 5 inhibitor, that is sildenafil, soluble guanylate cyclase stimulator, that is riociguat, selective prostacyclin receptor agonist, that is selexipag. All these have been tried and they are shown to improve the symptoms in patients with pulmonary artery hypertension and especially the cardiovascular symptoms, but the usage of them is limited to individual preference. The next connective tissue disease is mixed connective tissue disease, written as MCTD in short. This is a syndrome characterized by combination of clinical features similar to those of systemic lupus erythematosus, systemic sclerosis, polymyositis, and rheumatoid arthritis. Characteristically, these patients are known to have high circulating levels of RNP, that is ribonucleoprotein antibody ANA titers. This has been a controversial disease entity where some physicians and researchers argue that it's a separate disease, and a few others argue that it is a combination of multiple connective tissue diseases. Let's look at the clinical features. The clinical features include Raynaud's phenomena. Patients can also have polyarthritis. There can be swollen fingers. Patients can also have sclerodactyly. There can be esophageal dysfunction, pulmonary fibrosis. There can be inflammatory myopathy, renal involvement, including renal failure, can occur in up to 25% of patients. Laboratory features include high titers of anti-nuclear antibody, very high titers of RNP, that is ribonucleoprotein antibody. Patients will also have positive rheumatoid factor. This is seen in up to approximately 50% of the patients with mixed connective tissue disorder. Other evaluation is specific to systemic lupus erythematosus, systemic sclerosis, and also rheumatoid arthritis and polymyositis. Treatment for mixed connective tissue disease involves treating the specific symptoms and management of SLE or rheumatoid arthritis or polymyositis or systemic sclerosis symptoms. Next connective tissue disorder is Sjogren's syndrome. This is an immunologic disorder characterized by progressive destruction of exocrine glands mediated by lymphocytes. Characteristic features include dryness of eyes due to lacrimal gland destruction, dryness of mouth. This can be due to salivary gland destruction. It is also associated with extraglandular manifestations. Sjogren syndrome classically affects middle-aged females. There is primary Sjogren's and there is secondary Sjogren's. Primary Sjogren's is when the disease occurs by itself. Secondary is when it is associated with another connective tissue disease. These patients are at risk for development of lymphomas, which can occur in up to 6% of such patients. The most common of these lymphomas is maltoma, associated with the glands. Clinical features can be classified into constitutional, sicca symptoms, other dryness, and extra glandular features. Constitutional symptoms can be fever, fatigue. There can be weight loss also in such patients. Sicca symptoms are usually the dryness of mouth, which is called as xerostomia. There can be dryness of the eyes, which is keratoconjunctivitis sicca. Other dryness can be vaginal dryness, nasal, tracheal, and even skin dryness can be seen. Extraglandular manifestations include arthralgias, Raynaud's phenomena, lymphadenopathy, interstitial pneumonitis, cutaneous vasculitis, nephritis, and even lymphoma. Evaluation include history and physical examination. In particular, stressing about the history of ocular or oral dryness symptoms. Physical examination should focus on lymphadenopathy and presence of other autoimmune conditions. Laboratory investigations include presence of antibodies, that is autoantibodies. Important ones include anti-nuclear antibody, rheumatoid factor. Patients are also classically known to have anti-Rho or anti-SSA antibody or anti-La or anti-SSB antibodies. Other laboratory features include elevated erythrocyte sedimentation rate and C-reactive protein. Serum protein electrophoresis can reveal increased gamma globulin or hypergammaglobulinemia. Patients can also have monoclonal gammopathy. Other investigations include renal parameter evaluation, liver function tests, thyroid function tests, and even urine analysis. Ocular studies are performed to objectively evaluate for keratoconjunctivitis sicca, and this include rose bengal staining and Schirmer's test. Oral examination includes unstimulated salivary flow study and also dental examination. An important thing to note in these patients is due to excessive dryness and lack of saliva in the mouth, patients can come with recurrent dental infections. Patients can also have halitosis. Patients can also have oral ulcerations. Salivary gland biopsy can also be done, particularly the labial salivary gland biopsy. This demonstrates lymphocytic infiltration and also glandular destruction. In diagnosing Sjogren syndrome, EULAR, that is European League Against Rheumatism or American College of Rheumatology criteria is used. For the patient to be diagnosed as Sjogren syndrome, patient should have more than or equal to 4 points with at least one ocular or oral symptom, and the patient should not have any exclusion criteria factors. Labial salivary gland with focal lymphatic sialadenitis carries a score of 3. Anti-SSA antibody carries a score of 3. Ocular staining score of more than 1 carries a score of 1. Schirmer's test of less than 5 millimeter in 5 minutes in at least one eye carries a score of 1. Unstimulated saliva flow of, of less than 0.1 milliliters per minute carries a score of 1. Exclusion criteria includes radiation to head and neck, HIV disease, sarcoidosis, amyloidosis, a graft versus host disease, IgG4 related disease, and history of advanced hepatitis C virus infection. In treating the patients with Sjogren syndrome, ocular and oral symptoms need to be addressed, and such patients should be in frequent follow-up with the ophthalmologists and the dentists. Dry eyes can be treated with lubricating eye drops, local stimulation with cyclosporin eye drops can be used. For xerostomia, frequent sips of water can be used, or patients can have sugarless candies. Pilocarpine or civamelin can also help with the Zika symptoms. For patients with arthralgias, hydroxychloroquine can be used. In patients with extragrandular manifestations, glucocorticoids can be tried. But glucocorticoids do not have any role in treating the Zika symptoms. The last of connective tissue diseases is antiphospholipid syndrome, written as APS in short. This is an auto-antibody mediated thrombophilia characterized by recurrent arterial and venous thrombosis. There can be pregnancy morbidity in the presence of antibody against phospholipid binding proteins. This can be classified into primary or secondary antiphospholipid syndrome. Primary is when it occurs on its own, with secondary is when it is associated with any other autoimmune disease such as SLE. There can also be drugs which can induce antiphospholipid syndromes. Clinical features includes recurrent arterial and venous thrombosis. In women in reproductive age group, there can be recurrent abortions. A particular clinical entity called as catastrophic antiphospholipid syndrome is characterized by involvement of 3 or more internal organs, and this is a rapidly developing disease that can be life-threatening. Evaluation of antiphospholipid syndrome includes measurement of activated partial thromboplastin time, kaolin clotting time, dilute Russell's viper venom test, detection of antibodies against cardiolipin, prothrombin, and beta 2 glycoprotein. These antibodies are measured 2 times and 12 weeks apart. Diagnosis can be made in the presence of at least one clinical feature and one laboratory finding of antibody. In the treatment of antiphospholipid syndrome, after the first thrombotic event and once the diagnosis of APS is confirmed, warfarin is initiated with a target international normalized ratio or INR of 2.5 to 3.5. In pregnancy, morbidity is prevented by usage of heparin, as warfarin is contraindicated, and patients will also require aspirin in the dosing of 80 milligram per day. Patients with recurrent pregnancy loss can be tried with IV immunoglobulins. An important thing to note is glucocorticoids are not effective. For patients with catastrophic anti-phospholipid syndrome, these patients can be subjected to plasma exchange. They can also be treated with IV immunoglobulins. Glucocorticoids can also be tried in such patients, and anticoagulation is also used. Even with these, the mortality is very high in such patients.